and social ophthalmology. I welcome Dr. Jayashree Barua, ma'am, who is going to convene this session. The rest of the panelists will join us soon. So without wasting much time, let's start the session. I think the first presenter is yet to come. Dr. Ramya, paper 94, keratitis in recent measles outbreak in North Kerala.
Good morning. My report is on keratitis in a recent measles outbreak in North Kerala. So, as you know, measles is caused by a virus of Paramyxoviridae family, characterized by fever, cough, running nose, and the characteristic maculopapular rash. So, it's a highly contagious, serious airborne disease that can lead to severe complications and death. And despite the availability of vaccination, measles remains a significant global public health concern, particularly in regions with a suboptimal vaccination coverage. And it was once thought to be under control, but it has resurged in the recent years, causing significant public health problem. And primarily, it affects the respiratory tract and lymphatic system, but the virus can also disseminate hematogenously, leading to systemic complications affecting the various organs. Though the ocular manifestations are less compared to the respiratory and neurological system, the spectrum of conjunctivitis, keratitis, uveitis, and retinitis, what is known as the measles-associated ocular complications, can have a significant visual concern. And of these, particular concern is the keratitis, which can lead to painful eye, photophobia, and decreased vision. The pathogenesis of measles in keratitis involves the direct viral invasion of the corneal epithelial cells and immune-mediated inflammation leading to ocular damage. So, studying the clinical features and incidence will definitely help in understanding the pathogenesis of this and clinical outcome of this particular condition. So, this is a cross-sectional observational study done in patients who were admitted with clinical features suggestive of measles with any symptoms or signs of ocular involvement from October 2023 to February 2024 in a secondary eye care center in Kerala. We took a detailed history including the general ocular symptoms, vaccination history and exposure history, demographic features were recorded, slit lamp examination was done, fluorescein staining was done to look for the different staining patterns, and laboratory investigations were carried out. This is one of our patients with the maculopapular rash and the conjunctivitis, and these are the different staining patterns. Coming to the results, we had 30 patients. The maximum number of patients were in the 20 to 40 years of age group. All patients had fever with rash followed by these symptoms. The most common symptom was redness in 83.3%, followed by foreign body sensation and blurred vision. Coming to the ocular signs, congestion was present in about 71%. Though cornea was not clear in only 66.7%, on FS staining, we found that about 74% had some or the other kind of staining. It included superficial punctate epithelial erosions to small punctate opacities to large punctate opacities and filaments. Coming to the lab parameters, almost all patients had less total number of leukocyte count with a lymphocytopenia. Coming to discussion, the most recent outbreak in India was reported in Maharashtra in 2017, where the children were the most affected group. But in my study, it was the immunocompetent adult patients. The conjunctival inflammation was almost comparable to the previous studies. The corneal involvement, you can see the rate of keratitis in the previous studies was about 50%, but in our study, about 74% had corneal involvement at least on fluorescein staining. And my patients were seen by two physicians. So 50% of the patients received vitamin A as a part of their treatment regimen, depending upon the physician's preference. But there are no conclusive evidence from clinical trials to support the efficacy of vitamin A in these cases, preventing blindness. But interestingly, what you notice, 3 of our patients exhibited corneal involvement without concurrent conjunctival inflammation, suggesting that a thorough ocular evaluation should be performed in all measles patients. We know that ocular involvement is a well-documented thing in measles, but this outbreak underscores the critical need for comprehensive epidemiological and laboratory investigation in suspected measles cases regardless of vaccination status. Physician usually manages the eye conditions also. Particular importance is a keratitis because steroid treatment without proper slit lamp evaluation can lead to corneal thinning and increased IOP. So it's essential for ophthalmologists to be actively involved in the care of measles irrespective of whether cornea involved. In future, such research is needed to better understand the factors contributing to vaccine failure and the ocular manifestations, particularly in adults. And it should also explore the relationship between antibody titers and occurrence of keratitis. So to conclude, there has been a resurgence in measles, which was once thought to be under control, causing a significant public health issue. Despite widespread vaccination, a notable proportion of measles have occurred in individuals who have received a vaccine. Concurrently, a substantial set of these are associated with the corneal involvement, presenting a clinical challenge and necessitating a deeper understanding of the underlying mechanism. Thank you.
Very well presented, Dr. Ramya. I just want to know what were the total number of patients that you examined and how many patients had any form of ocular involvement amongst those?
Ma'am, we had 30 patients.
30 measles patients.
30 measles patients.
Okay, and out of those?
30 measles, no.
30 with ocular involvement?
Yeah, it means whoever physician has seen the patient with some or the other form of eye involvement has been referred to the ophthalmology department. So I have evaluated all those.
So your study is only on those patients with measles having ocular involvement?
Having some form of ocular discomfort or something.
And you didn't try to find out what is the percentage of the patients presenting with such ocular discomfort amongst the total measles patients?
I have found out only one, means maybe one or two patients more than this. Otherwise, all patients had eye involvement.
All patients had eye
almost
involvement?
all patients had at least conjunctival involvement, and many had a corneal involvement also.
Okay. Yeah. And what was your mode of treatment in these cases?
Most of these patients were treated with lubricants and antibiotic ointment as a prophylactic to prevent the secondary infection. But in severe corneal involvement, we have started steroids in few patients, and all resolved after 1 to 1.5 months.
So did you check the vaccination status of?
Yeah, I have taken the history, but in this we have because the age group is 20 to 40 years, there is a recall bias also, because documented history is not present in all patients, but most of these patients had a vaccination history.
They have taken vaccine.
Yes.
And yet they have...
they took a vaccine, but we had involvement.
Okay.
Thank you, ma'am.
That's all. Thank you. Suprita.
Good morning, everyone. My paper is on role of stress reduction in management of central serous chorioretinopathy. I do not have any financial disclosure. Central serous chorioretinopathy is a localized serous detachment of the sensory retina due to increased choroidal permeability. It is the fourth most common cause of non-surgical retinopathy. One of the association being the increased level of cortisol in the body. Psychological conditions like type A personality, depression, stress are more commonly associated. Hence, focus on the psychological health can further help us find a holistic management in to treat such a troublesome disease. My aim is to compare the result of nepafenac 0.1% eye drop alone versus nepafenac eye drop and stress reduction in treatment of central serous retinopathy. So, this is a prospective comparative study. My inclusion criteria is newly diagnosed cases of acute central serous retinopathy with moderate to severe stress levels on the basis of PSS scale, and my exclusion criteria are as follows: recurrent cases, evidence of choroidal neovascularization, automaculopathy on the fundus examination, pregnant females, any existing causes of hypercortisolism, and history of any ocular trauma or surgery recently. So, I divided the groups into two, one receiving nepafenac 0.1% eye drop only, and other with nepafenac we have added stress reduction treatment. And then stress reduction is done by lifestyle modification, meditation, and Jacobson progressive muscle relaxation. Then the data were analyzed. Here is the fundus image and the OCT image of one of my patient. Here in the fundus image we can see a dome shaped elevation And in the OCT, there is distortion of foveal contour and a hyperreflective area between the NSR, neurosensory retina, and the RP. So, coming to the results, the baseline characteristic of both groups, mean age is 43, and in group B, mean age is 42, and all the comorbidities are matched, and the gender distribution is shown in the right side. So, after 6 months, the visual improvement in group B is significantly more than group A, and there is significant stress reduction in group B. So, coming to the CMT, the CMT is significantly improved in 3rd and 6th month compared to group A. So, coming to discussion part, CSCR was found more in males in the age group of 40 to 50 years, consistent with the literature reviews. Statistically significant improvement in CMT was seen in both groups. From 3rd month onwards, CMT showed more significant improvement in group B than group A in 3rd and 6th month, and average reduction in PSS 10 score was -6.5, which is more in group B than group A. So, I conclude that central serous chorioretinopathy is a common retinal disorder in middle-aged men. So, the burden is more on the working population of the nation. As proved by the literature and researches, the psychological aspect of the etiology of these diseases makes it curable. Addressing the causes of these diseases, understanding the social and psychology of the patient is important in treating CSCR. Apart from the conventional treatment, the lack of awareness of common people about how stress can affect the eyes is to be addressed through more scientific approaches. These are my references. Thank you.
Well presented, Dr. Suprita. So, like we all know that stress reduction is a very important factor because it's more common in type A personality. So, you have compared the two groups with neparfenic and with neparfenic plus stress reduction. So, what was the onset at how much, because you showed the follow-up of 6 months. When did the changes start showing? Do you call, or how frequently you call the patient for follow-up?
On 1st month, 3rd month, and 6th month.
Okay, and when was the most significant improvement noted in the cases?
It started from 3rd month onwards.
It started from the 3rd month. Till the 3rd month, the values were same for both the groups?
Okay, yes.
Okay.
Are you still following up these patients to see the recurrent episode?
Oh no, ma'am. After 6 months only, on the patient.
Okay. Okay, thank you. Dr. Priyanka Shinde. Yes, the next presenter is Dr. Priyanka Shinde. Free paper number 284, Retinopathy of Prematurity Screening in Peripheral Districts of Odisha.
So the title of my study is Retinopathy of Prematurity Screening. So the title of my study is Retinopathy of Prematurity Screening in Peripheral Districts of Odisha. As ROP is the leading cause of preventable blindness in premature babies, my focus of the study is incidence and risk factor for retinopathy of prematurity in peripheral districts. Now we organized awareness plus training program for RBSK team members, the SNCU staff, and for the ANM and Asha Didi workers. Then we conducted camps also in 3 districts, that is Sundargarh, Kalahandi and Navranpur, with their help, and we documented each baby and classified according to the ICROP classification. Sometimes we get help from LVPI team also with the red cam imaging and the further management. Now total we have screened 179 babies, out of them 20 babies had ROP, and out of them 8 babies were referred to the further LVPI center for the further management, and 12 were asked for the follow-up. Now, according to the ICROP classification, the characteristic appearance of the demarcation line is the stage 1, and the disease is classified as the line progresses till the retinal detachment occurs, that is the stage 5 ROP. And there are different terminologies also, that is the threshold ROP and APROP. Now, in my study, the incidence of ROP was higher in male as compared to female, and the mean birth weight was 1500 gram, and the mean gestational age was 33 weeks. This is the table showing association between birth weight and retinopathy of prematurity stages. The incidence of APROP was higher in babies who were weighing less than 1.5 kg, and in the threshold ROP in between 1 to 2 kgs. This is a table showing gestational age with stages, which shows the mean gestational age was 33 weeks. And this is the association of zone and retinopathy prematurity stages. Mostly we have screened incomplete vascularization in zone 3, followed by these various stages of ROP. Now, we have concluded these are the risk factors. Even though there were risk factors in ROP babies, we found that only gestational age and birth weight, low birth weight, and oxygen therapy has statistical significance. So, the more importance should be given to the awareness about the disease risk factor, the treatment, the follow-up, health of the mother during breastfeeding phase, and documentation for its medico-legal purpose. Now, essentially, what I have experienced is essential 5 minutes before screening. It is essential because you can with your members to divide the duties, like who will do the counseling of the parents, who will do the sterilization, who will hold the baby. So that will help to ensure the process. And the role of ophthalmology, like in this era, that many ophthalmologists faces the logistic challenges regarding the untrained staff and the less awareness about the ROP. So teleophthalmology like RETCAM imaging and AI in ROP will definitely have this potential to overcome this problem. And these are my references, and thank you.
Beautifully presented. For how long did you follow up these babies?
Actually, ma'am, according to the staging and the types, some of them they were referred for the treatment. Like 8 were referred for the treatment, but only 2 were came for the follow-up. And in that the regression was seen, but after that they lost the follow-up. And other babies also we have screened, like if there is a zone 2, zone 3, stage 1, stage 2, we call them every 3 weekly. And if it is a zone 2, stage 2, then we will call them after 1 weekly, and we follow likewise.
Suppose you have a baby who you feel does not have any changes of ROP.
Right.
So what about those babies?
Any progression in ROP?
Yeah, will you follow up those cases, or you'll just
No, ma'am. We followed these cases 1 weekly, 2 weekly according to the guideline.
Yeah, and the good point was regarding teleophthalmology, but definitely RETCAMs, they are a bit expensive. So we can all plan actually for the group RETCAMs in the localized areas where you don't have easy access to your VR surgeons.
Yes,
okay.
Thank you.
The next presenter is Dr. Saroj Gupta. Free paper number 392, Protective Behavior of Time Spent Outdoors on Myopia Progression in Children.
A very good morning to So myopia has emerged as a significant public health problem across the globe because there has been a rapid increase in the prevalence of childhood myopia in last few decades. And we all know that genetic factors play a significant role in myopia, but there are some environmental factors also which are found to be associated with lifestyle and which can impact the onset and progression of myopia. And there are positive longitudinal studies that may ascertain the effect of environmental factors on the myopia progression. So this study was done to determine the influence of time spent on outdoors by children in daylight on myopia progression by following these participants longitudinally. So it was a hospital-based longitudinal observational study done over a period of 2 years at a tertiary eye care center, where children with 6 to 14 years presented with decreased vision and children with myopia 0.5 or worse were included, and children with refractive error other than myopia and children with family history of myopia or anterior posterior segment disorders were excluded from the study. So total 580 children were enrolled. All children underwent cycloplegic refraction and glasses were prescribed. The spherical equivalent were calculated for all the children, and children were followed every 6 months for 18 months, and at every visit cycloplegic refraction was done at every visit, and the spherical equivalent was calculated. The parents were asked to record the time spent in outdoor activity in daylight by child in hours per day at school, at home, during weekdays, weekends, separately on a calendar provided to them at the start of the study. And they were asked to bring this record at every follow-up visit. The time spent on outdoor activities in daylight was defined as like playing outside in the daylight, doing any activity, or even sitting in the daylight was considered as an outdoor, time spent outdoor. And this was calculated per day as the, at every visit by dividing the total hours of outdoor activity in a week divided by 7. And the participants were divided into 4 age groups. This is the statistical analysis we followed for data analysis. A total of 495 participants out of 580 completed 3 follow-up visits during the study period. And this table shows the profile of all the participants, including the spherical equivalent and the outdoor activity in hours at baseline, as well as the 4 visits, the follow-up visits. Every time we calculated the outdoor activity as well as the spherical equivalent in all the participants. The inter and intra-individual association between the spherical equivalent and time spent outdoor in hours in 3 visits were determined by repeated measure correlation. And this was calculated as 0.26, and which showed statistically significant negative directional relationship between the outdoor activity and the spherical equivalent. This is the graph which shows a repeat measure correlation graph, which shows a statistically significant inverse relationship between the outdoor activity and myopia progression, and this line, dashed line, represents the overall negative correlation between these 2 observations. So the magnitude of relationship was determined by mixed effect model method also, which estimated the effect of per unit time spent outdoor to change in spherical equivalent in subsequent visits after adjusting for the baseline activity in the age. So each hour increase in outdoor activity per day, means extra hour spent outdoors, had a negative effect on change in spherical equivalent, which was 0.6 diopter on subsequent visits as compared to the last visits. So this 0.6 diopter may not be clinically significant, but statistically it was found to be very significant. So discussion, our study findings are closely in line with Sydney myopia study, which was a cross-sectional study, which suggested the protective role of time spent outdoor by children, 12 years of old children. Similarly, North India myopia study, the prevalence of myopia was significantly less in children who were playing 2 hours outdoor per day. And there's another study, Sherwin et al., which indicated 2% reduced odds of myopia for each additional hours spent outdoor. But all these studies were cross-sectional studies. Whereas our study was a longitudinal follow-up studies. So the mechanism underlying protective effect of outdoor activity and light exposure remains unclear, but there are studies which show that there is release of dopamine from the retina on response to daylight exposure. And this dopamine, increase in dopamine level release inhibits the axis elongation of the eyeball. There are animal studies also to show that dopamine is released on daylight activity, and this decreases the axis elongation, which is responsible for decrease in progression of the myopia if the outdoor activity is there. So our study has multiple strengths and limitations. The strength is that there's a minimal recall bias, because all studies had a questionnaire-based recall, how many hours the child is playing outside. But in our study, we provided a chart to record the activity and bring it follow-up visits. So there are no recall biases in our study. It's a longitudinal study where we followed for 2 years. So there's a causal relationship can be established between hours spent in outdoor and progression of myopia. And it's a large sample size, 580 children were studied. Limitation, that's institutional nature. We have hospital-based studies, so it cannot be extrapolated on the general population. So to conclude, increased hours of time spent on outdoor activity at home, school may be a simple strategy to prevent the onset and progression of myopia. So we can advise this can be additional to the other modalities of treatment which are going on to prevent progression of myopia, like atropine therapy and all. So we can add this also to prevent the onset and progression of the myopia. And to our knowledge, this is the first hospital-based study which was done on cohort of children at tertiary care center in India. All studies in literature are cross-sectional studies, but we did a longitudinal study. These are references. Thank you.
Very relevant topic actually, seeing today's situation. But one factor which will be there in your study is that you have said, yes, definitely outdoor activity nowadays has a great role to play in this myopic
because
children.
now children have a screen time and they are
Yes,
not going outside.
but this is another factor which is going to affect the study. Like you have to even find out the screen time of these children. Because
near activity.
Yeah, for near activity. Because nowadays we want children to go more into the outdoor activities. Okay, so the difference in the screen time of these children, if they are using the screens, most of them are actually using the screens, will be another point towards your results.
Yes.
You know, that
Yes,
might
yes.
aggravate, that might remain the same.
Yes,
But
yes.
well presented and very relevant study.
Thank you so much. Thank you.
I've been a victim of this problem, but I would like to add here, not related to your subject. It's been a great help being this high myope after 40. That is why I never advise people LASIK or any other refractive surgeries. I can see what you see through this slit lamp without my glasses.
So there are studies which show that 10% are high myopes amongst all myopes. So these children will have complication. There's an increase in the, like in Asian countries, 80% is the incidence of myopia in school-going children. So it is increasing because the children are not going outside. So there are randomized studies where school, they have increased the break period for 2 hours. And there's a group in which they didn't increase. And they find that these children, the progression onset was less. So there are many studies in the literature when randomized trials are also there.
So
like adding to the curriculum of adding this to the curriculum of the school will be helpful, not only in physical strength of the children, but this also. So 1 hour extra outdoor activity in a school curriculum can be the implication of such studies.
Yeah. And like we have crossed China population-wise, we are on the verge of crossing them even in the terms of the myopic children.
In India also it is increasing, around 13% quoted the prevalence of myopia in school children.
Thank you, Dr. Saroj. The next presenter is Dr. Siddharam Jain. His topic is prevalence of amblyopia and its risk factors among children in South India using spot vision screener.
Good morning. My topic is prevalence of amblyopia and its risk factors among children in South India using spot vision screener. Amblyopia is common cause of preventable visual impairment in children affecting 1 to 6% globally. Photo screening devices and vision screening devices such as spot vision screener institute have been extensively studied and continue to be cost-effective, efficient, effective methods for detect risk factors for amblyopia compared to traditional methods. The spot vision screener is a portable tool which detects the refractive error up to plus or minus 7.5 diopters and cylindrical plus or minus 3 diopters. That is, was examined with significant refractive errors, anisometry, anisocoria, and strabismus. The aim of the study is to assess the amblyopia prevalence and risk factors among school children in rural Telangana, India using spot vision screener and assess the sensitivity and specificity of spot vision screener. This is cross-sectional study done in BB Nagar involving 714 school children, 5 to 10 years of age from October to November 2023. Screening was performed with spot vision screener. Children are identified with potential amblyopia risk factors were referred for a comprehensive ophthalmic examination to evaluate the confirm the diagnosis. Inclusion criteria, either genders who are school going 5 to 10 years, parents or school children who is willing to give informed consent. Exclusion criteria, children with non-vision threatening conditions such as conjunctivitis and external iodolema excluded from study and who are not willing to give consent. All participants underwent screening using spot vision screener. The device was positioned approximately 3 feet from the subject who focused on display of twinkling light. Upon initiating data capture, the screen to the children's face, spinning the circle while providing the distance information. The spot vision screener recorded pupillary diameter, ocular alignment, estimate of bilateral refraction with the data collection taking approximately 2 seconds per child. Following spot vision screener assessment, recommendation for complete eye examination for children having estimates of more than or equal to 1.5 diopters, myopia more than 1.5 diopters, hyperopia 3.5 diopters, and non-refractive issues like significant media opacity or strabismus more than 8 prism diopters according to the AIOCMT3 guideline 2013. Children identified with this condition re-examined by optometrist or ophthalmologist to confirm the diagnosis of refractive and associated amblyopia. Results of our study shows total were screened around 714. In that, confirmed diagnosis of amblyopia after optometrist is 65. And in this, males are more common. Age group we divide into 5 to 8 years and 8 to 10 years. It's more common in 5 to 8 years children. Type of amblyopia is refractive error correspond to 93%, followed by strabismus and vision deprivation amblyopia. Number of type of amblyopia is myopia is more common, followed by astigmatism and hypermetropia. Total number of screen is 714. In that, 84 is identified spot vision screener, but true positive with optometrist is 65. And sensitivity of this device is 87.86 and specificity is 97%. Discussion of our studies, doing this is as a rural study. This is around, our study shows 9.1%. It appears more because of its cross-sectional study. We didn't follow up the patients after giving, we didn't follow up after prescribing the glasses. We didn't confirm it. Other study shows Chaudhary et al. 2.9%, Kalikari et al. 1.1, Anjana Reddy 6.6. Age group in our age is 5 to 8%. Datta Chaudhary 11 and 16 years. Most common in male in our study. Primary causative factors in our study is refractive error. Shah et al. And remaining studies show anisometric amblyopia and myopia is most common study. And sensitivity of our spot vision screener was 87%. Remaining is Burgle is 82, Panda is 93%. Specificity is higher in our study is 97%. This study underscores the importance of regular eye screening, especially in rural areas where access to eye service may be limited. Early detection and appropriate management of amblyopia and its risk factors can significantly contribute to reducing the burden of preventable vision impairment among children. The spot vision screener with its non-invasive efficient screening capability has emerged as a valuable tool in detecting amblyopic risk factors, particularly resource limited settings. Thank you. These are my references.
So what was the treatment for those with the amblyopia? Like only the spectacles was given or
Our occlusion therapy were done.
was also advised?
Occlusion.
So but the patients were not followed up. That
No, they are coming, but this study were
From the
not
study,
included.
yeah.
Usually, what will happen, you prescribe after occlusion or glasses. There will be improvement that will be confirmed what will be the prevalence. But as it is cross-sectional, only we identify the prevalence of risk factors for related to this amblyopia.
okay.
Myopic. No, we are, no, it's not there. Not there. Yeah, this study. Yeah, that's anisometric. Yes. Okay. Okay, thank you.
The next presenter is Dr. Ipsita Das. Free paper number 904, a study on clinical presentation of patients with low vision and effectiveness of rehabilitation.
Good morning, everyone. I'll present a paper on a study on clinical presentations of patients with low vision and effectiveness of rehabilitation. The low vision essentially refers to a level of vision that prevents a person from performing customary visual activities such as reading, writing, orientation, mobility, driving, etc., even with standard or conventional optical correction. Few studies have shown that the prevalence of low vision is up to 60% among the elderly population. Such patients may be benefited by the significant residual usable vision with the help of low vision aids for day-to-day activities. A low vision aid conventionally refers to a device that improves or enhances the residual vision by magnifying the image of the object at the retinal level or by modifying the environmental factors. The aims of our study was to study the common etiological conditions causing the low vision in patients, to study the demographic factors in patients with low vision, to study different base suitable low vision aids advised and their compliance rate, to study the improvement in the quality of life of the low vision patients after using low vision aids. Thus, this hospital-based observational prospective study was done in a tertiary care hospital in the northeast part of the India in 1 year duration. All patients with BCVA less than 618 in the better eye, patients above 10 years to 70 years of age and stable ocular condition were included in the study. Whereas patients below 10 years of age, above 70 years and below 70 years of above 70 years of age, patients with acute or progressive ocular disease not willing to use any LVA or differently able people are excluded from the study. Patients with BCVA less than 618 in the better eye were considered as having low vision. 80 such low vision patients were thoroughly evaluated regarding causes of the low vision and were given counseling and trial for different low vision aids. The best suitable low vision aid which had been accepted by the patient was advised. Each patient, whoever was advised low vision aid, was asked to follow up after 3 months. Patient's response was noted regarding quality of life before and after using LVA and purpose of LVA use by a questionnaire. The quality of life was assessed by the level of difficulty in performing these 7 visual tasks. Each difficulty level was allotted scores as extreme difficulty as 1, moderate difficulty 2, mild difficulty 3, no difficulty 4, and stop tasks as 0. So these are the results. This is the age distribution, so shows maximum patients in between the 20 to 29 years with mean age 36.6 years. Most patients were male and mostly are from rural areas. Among different etiologies, the most common etiology was ARMD, followed by amblyopia, followed by other causes like hereditary dystrophies, maculopathies, chorioretinal diseases, optic atrophy, nystagmus, and other causes. These are the BCVA for distance in the better eye on presentation, mostly were in between 618 to 660. This is the BCVA for near in the better eye on presentation, mostly were from N8 to N24. These are the different types of LVA used. Out of 80 patients with low vision, 58 patients accepted the low vision aids and therefore the best suitable LVA was advised. However, only 40 patients showed the compliance and came for follow-up. So these are the different low vision aid advised and the graph shows the number of patients advised and the number of patients who are showing the compliance. The magnifying spectacle was the most commonly prescribed LVA. So the overall compliance rate was 68.96%. Most compliance was shown in magnifying spectacle followed by linear magnification, whereas telescope shows least compliance. These are the purpose of the LVA use reported by the patient on follow-up. Mostly the purpose was used in reading related tasks. The quality of life assessment was done by these 7 visual tasks. This is the post-LVA and pre-LVA mean score in doing this task. And this shows a statistically significant improvement in the quality of life. So this hospital-based prospective study aimed to identify the common etiological conditions of the low vision, demographic patterns, and the acceptance and effectiveness of the low vision aids. Our study found that the age-related macular degeneration was the most common cause of the low vision, followed by amblyopia. These findings were consistent with the study by Khan et al. Identified the retinal disease as the predominant cause of the low vision. Pattern of advice of different LVAs were similar by studies by Khan et al. And Kim et al. Low vision rehabilitation is associated with an increase in the functional status and improved vision. These positive changes are associated with personal and social benefit, including increased autonomy and enhanced quality of life. As an individual becomes more independent and is able to perform outer activities, the severity of depression also decreases. These are my references. There is no conflict of interest and no financial support. Thank you.
So how did you decide which LVA to which patient? Was the occupation or the type of work taken into consideration?
Actually, the patients were given the different options of the
choice,
LVA.
yeah,
And the, with respect to the occupation and what is the need of the patient, whether the patient needs more distance, like distant vision or near vision, and what is the like occupation of the patient, whether is a homemaker or any reading related task, clerks. So according to that, we like whatever the patient accepted the most, we advise that.
So actually it's not only the distant vision which you need to see, since you are talking about handheld magnifiers or spectacle magnifiers, and you said most common problem was with reading.
Yes.
So you need to mention even the near visual acuity, which is also equally important. Like 618, you have mentioned, no, the remarcation. You need to just mention what was the disability with the near work also, near vision. Okay? Well present.
Dr. Vishal Prakash. So the next presenter is Dr. Vishal Prakash Nandeshwar. Free paper number 21, intraocular pressure and central corneal thickness relationship in industrial workers in Rourkela, Odisha.
Good morning, everyone. My topic is the intraocular pressure and central corneal thickness relationship in industrial workers, Rourkela, in Odisha. Introduction. The eye is a delicate and complex organ susceptible to various occupational hazards, particularly in industrial settings. And industrial workers are exposed to numerous risk factors that can affect their ocular health, including chemical splashes, dust, and ultraviolet radiations. Intraocular pressure and central corneal thickness are two crucial parameters that play a significant role in maintaining the structural integrity and function of the eye. Research has shown that alteration in IOP and central corneal thickness can be indicative of various ocular and systemic diseases. Elevated IOP is a primary risk factor for glaucoma, while abnormal CCT values can influence IOP measurements and glaucoma diagnosis. The relationship between IOP and CCT has been explored in various populations, but data on industrial workers, particularly in Eastern India, is limited, and that thus our study wants to emphasize on the IOP and CCT relationship in them. Aim and objective. This study has been undertaken to determine the relationship between central corneal thickness and intraocular pressure in industrial workers, Rourkela. My study design was population-based cross-sectional study. 200 eyes of 100 patients were evaluated. Industrial workers from Rourkela visiting to IOPD of Ispat General Hospital, Rourkela. Study center was Department of Ophthalmology, Ispat General Hospital. Study period was 6 months. Inclusion criteria: all industrial workers who visited IOPD of Ispat General Hospital who given consent. Exclusion criteria: previous intraocular surgery, eye trauma, intraocular inflammation or tumor, significant ocular media opacities, dense cataract, corneal pathology. Those who have not given consent were excluded. Methodology: a population-based cross-section study was carried out on industrial workers from Rourkela who visited IOPD of Ispat General Hospital. After obtaining written informed consent, all participants underwent detailed evaluation including medical and ocular history and examination. The central corneal thickness was determined with ultrasound pachymeter and intraocular pressure by the Goldman applanation tonometry. All measurement of IOP and CCT were taken between 10 a.m. to 12:30 p.m. to control for diurnal variation. The measurement of both CCT and IOP were carried out by a single examiner to minimize inter-observer error. Data was analyzed using Spaces software, and p-value of less than 0.5 was considered significant. These are the results. Age distribution: 47 to 56 years was the age range. 51.5 is the average age. Gender distribution: females were more in my studies. 58 females, male 42. Results: these are the relation between the IOP and CCT with 0.002 significant p-value. A total of 200 eyes of 100 eligible participants were analyzed in this study. Multiple regression analysis shows significant positive correlation between CCT and IOP in this study. P-value of 0.002. The linear regression formula for this study was IOP is equal to 7.87 plus 0.016 CCT in mmHg. This indicates that a rise of CCT in 10 micron leads to an increase in IOP of about 0.16 mmHg. Discussion: previous research has shown conflicting results on the connection between IOP and CCT. Nonetheless, our result aligned with the research carried out by Alberta et al., where they showed positive association between IOP and CCT of the right eye. Correlation coefficient and the left eye. Similarly, Irgat and Elrium demonstrated the noteworthy and statistically significant positive correlation between IOP and CCT. Alcordi found moderate correlation between IOP and CCT similar to our study. In a survey by Nijabet et al., there was also direct relationship between CCT and IOP with a significant value. Additionally, this indicates that rise in CCT of 10 micron leads to an increase in IOP of about 0.16 mmHg with a usual range of 10 to 21 mmHg. In our study, IOP was within the normal range, although there was a variation in IOP with the central corneal thickness of patients. Like earlier research, our study did not find statistically significant difference between IOP of the two eyes. Key-Metal found that non-glaucomatous patients had comparatively less frequent IOP asymmetry between bilateral eyes. This conclusion: central corneal thickness could result in systematic error in the measurement of IOP by applanation tonometry in study population. The CCT should therefore be considered in the management of glaucoma, especially in the industrial workers. These are my references. Thank you.
So what any difference? You told it was more significant correlation in males and females. Was there any difference?
No, ma'am. I have not compared female and male. In study population, females were more in my studies.
Okay, so you didn't compare
I
that.
didn't compare.
Okay. Okay, nice presentation.
Thank you.
Dr. Aanchal Tripathi? No. Dr. Markandeya Singh? So, thank you all for being here and presenting your paper, and thank you Dr. Daliwal Ranjit Singh sir and Dr. Jayashree Barwa ma'am for being the panelists. Shall we have a group photo?